we'll turn it over to you.
Right. Currently in the United States, there's over 1.2 million cases of COVID-19, and it looks like we're continuing to have somewhere between 20 and 30,000 new cases a day. So, in the last week, we've, in the United States, have more cases than Spain in 1 week. So I think this is not something that's going to go away really quickly, and the big question is going to be how it's going to affect us locally. I sat in on the National Ground Rounds talk today for the emergency departments, and looking at Albany in Georgia. They're a community not dissimilar from Missoula. They're not really on any main thoroughfares, so they're kind of a little more geographically isolated. And they had basically they traced their whole outbreak back to a single initial patient who came to a funeral and was at a funeral home. There were 2 different funerals going on there, which led to, kind of widespread community transmission. That unfortunately, was when they had a testing turnaround of around 4 days. So they'd actually discharged or transferred the patient, back to his home state by the time they got the positive COVID test, and he'd been on non-invasive ventilation. So it was really a kind of an eye-opening thing for what could happen. Their hospital, which is just slightly bigger than St. Pat's, was averaging, a volume of 160 patients that were all COVID positive. So that's more than our current volume that we could take in the hospital, with a large percentage requiring the intensive care unit. There were issues. They wanted to try and transfer patients out because there were areas in the region that they had extremely low censuses, and they were refusing to accept patients, which is something I think, for us to think about as well. But ultimately EMS did end up transporting a number of those patients to other facilities. So that is, a conceivable, something that could happen here in Missoula. So I think the big thing I wanted to point out is that the CDC expanded their, symptoms they consider possibly consistent with COVID, from fever and shortness of breath and cough to include things like myalgia, GI symptoms with vomiting and diarrhea, chills in the absence of fever, chills or shaking, as well as sore throat, and Dennis is nodding something. So that's going to encompass a ton more patients. So we do need to think about screening with those questions. And from my perspective in the emergency room, I am testing all those people, even if they're not getting admitted. The testing algorithm really comes down to, symptomatic versus asymptomatic patients still. And then the decision for the rapid testing we have in the emergency room, we're still reserving those for patients who are, inpatients or healthcare providers, and then patients who might need emergent procedures, like if they have to come into labor and delivery emergently for a cesarean section, or patients who might need to go to the operating room urgently. We're trying to test those patients. So,
what's the turnaround time for that, Mike, the rapid?
They say 45 minutes, but most of the time it's really over an hour, and that's like calling every 20 minutes to make sure they're doing it. If you don't know someone's going to be admitted to the hospital for sure at the beginning, they won't run the rapid one too. So just for example, the patient who was brought in, the trauma patient with a GSW to the chest the other day, we did rapidly test him in anticipation. Well, we intubated him using COVID precautions, but in anticipation of him maybe needing to go to the operating room, we also did the rapid test for him, and it took just over an hour. So the other test is really going to the state right now, and that's, again, ideally 24-hour, but not uncommon 48-hour turnaround for those tests. That's the kind of test we're sending for patients before they go to the operating room if it's a planned procedure. So we're able to use that to determine what their rough COVID status is. The sensitivity and specificity for these tests is still a little bit unknown, and I think we can't rely completely on a negative test either. So I think the other question I've had recently is regarding the serologic testing, the blood testing for antibodies. And just so you guys know, the FDA really opened that testing up to companies to develop their own tests without a lot of oversight. So there are a ton of tests out there. Some of them are extremely poor, around 50% sensitive. There's 2 tests that are apparently pretty good that actually have been recommended by the FDA, but they haven't gone through the very scrutinous process they normally do for these types of tests. A lot of people are wanting these tests, and to make it even more complex, these are antibody tests to look for IgM, which is the antibody that is the acute antibody you see in infections, and IgG, which is the delayed antibody. So IgM typically starts, you start to see that around a week, whereas IgM is around 2 weeks. But it looks like for COVID, a lot of patients do not develop IgM who actually have the infection. And a lot will develop IgG antibodies first. And that, again, may be related to how bad a test they're running. Those serologic testing really have no benefit in determining who actually is infected, or even if they had an infection, as some people who've never had documented infection will develop antibodies. So it's really, there's not a great place for those yet. I think we need better tests and, more information. And Providence has put out a document that really explains kind of that. So if people are interested, I can forward that to Dave. But that testing, if you hear about it, is not as clean as we'd like. So as far as how the new CDC guidelines for suspected COVID symptoms are going to affect us, we do need to include those in our daily screening. And you're going to need to notify a supervisor if you do have any of these expanded symptoms and decide about getting tested.
And Mike, those are, Jeff, you can jump into where they are on Lad Tech for people.
Yeah, so it's in the forms section of Lad Tech, and what we're going to require is that every one of our employees sign on every morning before shift and fill out that form. So we have documentation of everybody self-screening themselves. And we'll include temperatures in that. We haven't decided if that's going to be a self thing or if currently we're doing the managers are still doing their temps. But
Hey, Mike, would it be the case that it's 72 hours before a shift, you should be asymptomatic? So if you had any of those things in the 3 days before your shift, you should call the manager and kind of talk through it, and then they would maybe contact you for advice?
Yeah, I think that's reasonable. So
3 days.
Yeah. But I mean, if you develop those symptoms, you need to, even if you're at work, you need to notify someone. So.
Okay.
It still remains to be seen what's going to happen here. I don't know. I do have concerns that because we have, some moderately large grouping of vulnerable patients in our community and almost no exposure to the COVID virus here, I don't think there's going to be widespread, community resistance to it from prior infection. So I think we're still pretty vulnerable to this. It really just kind of remains to be seen what's going to happen with, releasing the social distancing restrictions. And if people start traveling in here, for the summer to do, fishing trips and to go to the mountains, and we start bringing it in from other places. Alternately, there have been, talk among people that, hey, Montana barely has any cases. Maybe we should go there. That's another thing to be aware of, is that, travel history, I think, is going to become important again. So I think it's always important for this, to be honest, but, because we had some community transmission, but it didn't become widespread. So now we really need to start thinking about, does this person with, shortness of breath or vomiting and diarrhea, did they just come from, somewhere else where there's a number of cases? Did they have an exposure to someone who's known to be positive? So, and then err on the side of using PPE. We have it available right now, and we should be using it. So.
Mike, do you want to address the canceled calls and how we're going about how we're doing that?
So we put into place the protocol to offer not to transport patients with informed consent, and that really didn't go as well as we'd hope. It looks like a bunch of These did not get online medical control for the refusals, and without having widespread community transmission right now and overwhelming our system, I think probably will avoid that right now, but we'll keep it in place as something we may reinstitute if things change locally.
So just to be clear with that, Mike, you want us to go back to our old standard of just, we're not suggesting that people stay home. We might go back to that, but for right now, it's, if they want to go, we're not telling them like we don't think you should, right? So the form that we came up with, we're not going to use for a while.
Yeah, well, we weren't using the form well, and we weren't using the online medical control part of it. And without having the widespread community transmission, I think that we should probably just go to that business as usual, and then we should keep that as an option to put out there if things change. So,
okay. Don or Jeff, do we have anything you wanted to jump in about with that, or ask Mike about that, how we're going to go about it?
That sounds good. If we need to go back to it, we go back to it. But right now, I mean, our closest case is Helena.
yeah. So,
Okay.
yeah, I think just leaving it out as an option in the future is good. But right now, we'll just go back to business as usual. So,
yep.
Which means actually taking vital signs and evaluating patients that call 911, and not because we need to make sure we're still doing a good job documenting refusals for patients. So that's been something we've struggled with in the past, and I'd like to make sure that we don't forget about that. So do an assessment. If the patient refuses an assessment, and they, we need to document those refusals well. So
Great. Anybody have any questions for Dr. Kremkau here? Anybody else? Jeff or Don, anybody?
Good.
As far as medical care, I think there's not been a ton of new stuff out there. It looks like there was a lot of discussion about whether the patients who were on the ventilators really had acute respiratory distress syndrome. And it looks like the patients who probably are on the ventilators for a long term do actually have regular ARDS. Their compliance is probably not that good. I think a lot of that data that showed that the lung compliance, which is the ease of how well you're able to deliver a breath, that it was really low, which is atypical for ARDS. I think that came from a lot of the early intubation strategy, where they were probably intubating people very early who had low SATs that they maybe could have maintained by other means. So lung compliance, they think there's kind of two groups. There's the people who get sick earlier that have poor compliance, and there's people who get sick that have low oxygen but normal compliance. So I don't know if that's going to impact us a ton right now. I do think it's where we need to be thinking about providing high flow supplemental oxygen, and positioning the patient in the lateral decubitus position, versus the patients who are developing altered level of consciousness and probably need invasive ventilation. So,
and Mike, can I ask just one question here, Mike? And this is just, I don't know, it's just hypothetical, but is there any literature out there that's helps predictors in regards to like end-tidal CO2 in patients that you're reading? Is there anything in there that's predicting?
No, these patients often have really high respiratory rates. So most of them have, they're not hypercarbic until they start to get confused. So,
okay.
I mean, if you see patients with a decreased level of consciousness, they're still awake, but not normal. That's when I would think about looking at that end-tidal CO2. I'd probably use it in anyone who's in respiratory distress if I can. But for sure, those patients I would start to worry about are developing, hypercarbic respiratory failure in addition to the hypoxemia. So,
perfect. Thanks.
Mike, where's the pendulum at with CPAP and how effective it is, apart from it being an aerosolized generating procedure?
Yeah, there's still a lot of debate of the best non-invasive mode. There's a huge trend towards the nasal high flow oxygenation, because it's really been shown probably not to be aerosolizing. The droplet dispersion in patients, like from models, is not much more than just, wall oxygen with that. So that looks to be pretty safe, especially if you're using a face mask over the nasal oxygenation device, so like a surgical face mask. The CPAP, there's a lot of debate on. And there's a good trial in pneumonia, including viral pneumonia, that with this, it's called the Florali trial, where they looked at the nasal oxygen, and it seemed better, and it did avoid intubation in some patients, but just delayed it in others. Whereas, the CPAP really didn't looked like there was actually a more, higher mortality and no benefit as far as preventing invasive ventilation. There's some people who are having better luck with it in this, but the data is not really published yet. So I think we just don't know exactly what the best non-invasive mode is. Theoretically, there's some evidence that CPAP may be better than BiPAP for this, but I haven't seen any real data that shows that one way or the other.
So is CPAP something you'd like people to call in for now, or is it just if they feel like they need it, use it?
Yeah, I think if you can't manage, if you can't oxygenate them despite like switching to a face mask, having the patient change positions, then it is an option, and it is an aerosolizing procedure, especially with the device we have where we can't develop these really good seals. So I know some people talk about using nasal supplemental oxygen underneath it. I don't think that that's something that we should probably be doing. Well, most of all, because it's logistically really difficult, but also because I think that's only theoretically beneficial.
You're talking about underneath the CPAP mask?
Yeah, there's some people who are suggesting that.
Well, doesn't that hinder the seal even more? I mean,
Well, they're saying that the masks, and I think these are probably hospital face masks with straps that are better fitting, but they're still getting good seals with that. And this is actually a lot of Scott Weingart stuff from the MCRIT, and I am not convinced that adds a ton, to be honest. So,
But Mike, is there value to us using a cannula, the cannulas that we have at high flow, like our own cannulas, because they're not?
it's not going to work super good, because it's not designed to do that. It's also, not humidified, so
Right.
it'd be really uncomfortable. Patient's probably not going to tolerate it very well.
Okay.
So
yeah,
it doesn't have the seal at the nose is the important part of that, though.
Okay.
Probably the real benefit is having those, well-fitted nasal prongs that are on the high flow nasal oxygenation systems. So,
okay. Is that something you think we should be looking into getting, or?
I think it's going to be something we're going to want at some point. I don't think it's going to be available right now, because
Right.
I bet you can't buy one if you wanted it.
Okay.
So. I don't really have too much else. Yeah, I think it just really kind of remains to be seen how this is going to work, and it seems to disproportionately affect higher population density areas, just because I think the transmission is so much higher. So this average, R0 transmission that they talk about is probably, a mixture of the really low transmission areas where we are and super high places like New York and California. So I think we'll just have to wait and see what happens. If we get a bunch of cases at, one or two of the nursing homes that could or the jail, it may dramatically impact what we're end up doing here. The Poverello Center would be another place, so, but right now I think we just it's waiting and seeing, and we got to remain diligent. So,
Mike, is there any feedback from St. Pat's on drop off, just how we're doing with interaction when we get to the door?
I think it's going better. I think that, waiting out there is the hard part. So making sure you coordinate which way you go into room 5 should always be, feet first into that room. And I think I'm trying, at least for me, when there's someone really sick coming in, whether it's medical or trauma, I'm trying to meet them in the bay to help start assessing the patient early. So
that was helpful the other day when you're out there for that. Yes, Billy.
Yeah.
It was helpful. You kind of.
Yeah. But what was unhelpful is, personally, I didn't communicate everything that I'd already seen about this guy. And so I felt like there was a lot of and it was my bad communication, partially because we have these PAPRs on for some of the staff. There's that negative pressure thing in the room, and it makes it hard to communicate in there. I take full responsibility that I didn't communicate what I'd already evaluated about this guy. Was that I thought we needed that he was probably decompressed already if he had tension, which was great, and that getting him on the ventilator and getting definitive chest tube in was really what we needed to do right away. And it took a little bit of time for everyone else, I think, to catch up with my thoughts because I wasn't communicating them well. So that's a good lesson, I think, for all of us.
So Mike, just to recap, the only thing we're changing today is the cancel calls. Meter dosed inhalers, as long as we can still get them, aerosolizing treatment, that's all stays the same until correct?
Yeah, I would keep all that stuff the same. And then we talked about the expanded symptoms to consider as well. So.
Great, Mike. Anybody else have any questions for him? All right, this is all recorded. I'm going to put it on a LabTech, or if it's too big of a file, I'll put it on our YouTube channel. Thanks, everybody. Mike, thanks for taking the time for doing it.
All right, thanks, guys.
Okay, take care.
Bye.